I'd like to welcome everybody to our first Neela Nights of the 2024-2025 season. We are honored this evening to have Dr. Dinesh Kalra, who's a distinguished professor of cardiology from the University of Louisville. Dr. Kalra is a professor of medicine and radiology at the University of Louisville School of Medicine. He also serves as a vice chair of quality in the Department of Medicine. Dr. Kalra is an international expert in multimodality imaging, preventive cardiology, lipidology, and infiltrative cardiomyopathies. We're very happy to have him this evening talk to us about coronary calcium scoring and coronary CTA evaluations for our patients. So without further ado, it's my pleasure. And again, thank Dr. Kalra for joining us this evening. Go ahead, Dinesh, take it away.
Well, I really appreciate the opportunity, Dr. Mintz, and thanks to the NOA and to the organizing committee to make this happen, because this topic is sort of an evolving field, as you and I have discussed. And so even though I'll touch on calcium scoring, I think the data on calcium scoring and risk prediction is so robust. I wanted to focus most of my efforts on the evolving space of coronary CT angiography and really how it helps us refine both risk assessment and especially guide therapy. So I'm really passionate about this topic, and I'll show you some of the trials that are going on in this space at the end of this talk. So I have no relevant disclosures. My learning objectives tonight are to discuss the key developments in atherosclerosis imaging by CT, including CT angiography, as I mentioned, and then show you what new advances have occurred in this field that now link not just plaque stenosis, which is what we've been doing with CT for the past 25 years, but actually plaque morphology, characterization, and then going into the field of plaque regression, which is now possible with the new lipid lowering therapies that we have. And then I'll talk about the role of CT in guiding how we actually manage our patients. When do we intensify treatment? When do we worry about somebody being at particularly high risk? And all of that data is now available with CT. So this was going to be my audience response question, and I'm going to go over it quickly, and we'll revisit this at the end of my talk. But it's which of the following features on CT angiography is not associated with a higher risk of incident myocardial infarction? So is it a high index of inflammation around the coronary, high percent atheromal volume, so a lot of plaque burden, or a very densely calcified coronary plaque, what we call 1K plaque, which exceeds 1,000 Hounsfield units? Or on the contrary, is it a large amount of plaque that has low attenuation, i.e. less than 30 Hounsfield units? Or is it when your artery is positively remodeled, what we call the Glagol phenomenon? So why are we talking about all this? Because our risk prediction models are still imperfect. So this is a large database of 4.8 million myocardial infarctions. And if you look at the number of people that were correctly identified beforehand, it was quite small. So 50% of patients had no prior symptoms. 1/3 of them had no prior PCP visit. 1/3 of them had no risk factors, and the majority of them were not taking any preventive therapy. So most patients who come in with a myocardial infarction, I'm sure all of you have seen, have no prior indication that they had coronary disease. It just strikes them out of the blue. And as I mentioned, many of those are asymptomatic. And so we can't use symptoms alone or risk factor prediction models alone with the current tools we have, namely the pooled cohort equation and prevent equation or score, whatever you use to really identify risk on a granular level. Yes, on a population level, those calculators do a decent job. So they tell you which populations are generally at higher risk, but when you drill down to an individual patient, that's the statistic as to identifying which of my patients is going to come in with a heart attack is somewhat poor. And even when you are able to predict risk in the clinic and you start patients on preventive therapy, most of them stop it. And that I hope to show you that the power of imaging is not just in helping the physician identify who's at risk, but also for the patient to stay worried enough that, yes, I see plaque in my coronaries, whether it's calcium or by CTA, and they tend to adhere more often to therapy, reduce the risk factors better, as opposed to just telling them you're at intermediate risk based on the pooled core equation. Now, we know for the past 40 years that when people develop myocardial infarctions, these are usually occurring in non-obstructive plaques that rupture and then cause sudden occlusion over the course of a few minutes. So this is data from 1988 from a study by John Ambrose that 68% of patients on angiography had less than 50% stenosis on their angiogram, which was done a few months to a year prior to them coming in with a myocardial infarction. And you would think that, yes,
Dinesh,
yeah.
the slides are not moving off the initial intro.
Oh, I
Uh,
apologize. Okay.
you were so excited that and we were mesmerized listening to. Go ahead.
Thank thank you for pointing that out. So this was the I think my mouse was on my other screen rather than on the second screen, which is showing the slides. So this was the data showing the 4.8 million myocardial infarctions where most people did not have symptoms or were not predicted by the current risk equations. This is the data that I'm talking about, that when people undergo a myocardial infarction and they've had angiography before that, most of these individuals do not have tight stenosis. And you would think that in the current day and age, with statin use, because this data is old from the 1980s, iconic is data that is more relevant to today's day and age. Using CT, again, less than 50% of stenoses are tight. And so most stenoses that cause myocardial infarctions, when you look at them 3 months or 6 months prior to the event, they tend to be non-obstructive. Since we're going to be talking a lot about plaque and plaque regression, I want to clarify that there's differences in how invasive angiography views plaque and how CT angiography views plaque. And this distinction is important because with invasive angiography, you're looking at the lumen. So if somebody has progression of stenosis from 40 to 50%, we say that's progression. And by regression, we means that the percentage diameter stenosis has actually gone down. It's a little different when you look at CT because CT is showing you the vessel wall and it's quantifying plaque volume in the vessel wall. So it's not just a luminogram, it's a luminogram plus a picture of what's happening in the vessel wall. So CT, for example, can show you that the diameter stenosis is not changing at 40%, but the plaque volume has increased. And how does that happen? It happens because of the concept of expansive remodeling, the Glagov phenomenon. So your plaque volume can increase, but the vessel can expand outwards to accommodate that plaque, leaving the luminal diameter unchanged. So that is still plaque progression. That would have been missed on invasive angiography because you would have said, well, the stenosis percentage is the same, but the plaque has actually grown in size. And that's, I think, a key advantage to using CT. And the same thing can happen with plaque stabilization. Plaque volume may stay the same, but if the artery remodels inwards, then the percentage diameter will change. So I think these are key important concepts as we tend to utilize CT now to measure whether plaque is changing. Now, myocardial infarctions in young adults has always been a problem. I showed you earlier how most people don't have risk factors or not taking medications. When people come in with their first MI and they're young, all of our risk equations tend to sort of fall apart. 70% of these individuals would not have been classified as recommended for statin therapy before they have their first heart attack, because age, as you know, is a very powerful predictor of risk in the pooled core equation or the score equation, whatever equation you use. So we're trying to see how to better identify individuals who would qualify for preventive therapy at an earlier stage in life. And this is data from 2003, the COSA study in JACC, but even more relevant current data from the Harvard Young MI study, or a large study going on in India where a lot of people, South Asians, have MIs at a young age, called the Norin STEMI study, still bears this out, that a lot of young individuals would not have qualified for statin therapy just using risk equations alone. So one of the beauties of using coronary CTA as opposed to using calcium scoring is that calcium scoring, even though it doesn't require contrast, just shows you the calcified plaque, which is really the tip of the iceberg, because the vast majority of plaque, 80%, is underneath the water level. And so soft plaque or non-calcified plaque will not be detected by calcium scoring. Whereas when you give contrast, you're not only able to see calcified plaque, you're able to see what we call mixed plaque or partially calcified plaque, and you're able to see soft plaque or completely non-calcified plaque. So you get a more holistic, comprehensive picture. And as I'll show you, you're not just able to see only calcium, you're also able to see what's going on in the fat outside of the coronaries, because there's new data coming out that inflammation of epicardial fat or pericoronary fat has a bearing on who develops heart attacks later. So CTA is quite powerful. We used to use it in the past only for percentage diameter stenosis to guide decisions about who needs to get stented in symptomatic people. But if you shift your viewpoint towards asymptomatic people or prevention, it tells you so much more. It tells you which plaque is nasty looking or vulnerable plaque, i.e. which plaque is ulcerated, or where there is lots of positive remodeling, or small areas of spotty calcification which reflect where hemorrhages occurred in the plaque and now this plaque is healed. So an invasive angiogram only tells you one thing, which is percentage stenosis, whereas a CT angiogram gives you a whole wealth of information on other plaque aspects that are crucial to determining risk and guiding management. Now, there are many modalities, as you know, including some invasive ones, which are really superb because they have excellent spatial resolution of 0.01 millimeters, for example, with optical coherence tomography. These can pick up plaque. But the biggest advantage of these is they're invasive. So, for example, intravascular ultrasound or optical coherence tomography or near infrared imaging of the coronary spectroscopy, they all give you wonderful plaque characterization. But the problem is you have to thread in a catheter into the coronary, and it takes some time to get all this data, and it exposes the patient to complications, the risk of complications, and it's expensive. CT, on the other hand, is non-invasive, and it gives you what we call whole heart atherosclerosis. So you get a picture of all three vessels at the same time without having to put in a catheter individually in one vessel, take it out, put it in another vessel, take it out, put it in the third vessel. That's very impractical. And furthermore, you cannot keep repeating that to look at plaque regression or progression serially over time. So that's why it's become the modality of choice in looking at coronary plaque and changes over time. One of the other things that's happened that's really boosted CT to the forefront is, I mentioned, the whole heart atherosclerosis aspect, but radiation doses have now come down. When I first got into this field, radiation doses used to be 20, 25 millisieverts. And I'm sure Dr. Mintz remembers, we really were selecting patients very carefully at that time to send them for CTA because of this amount of radiation. Now the radiation dose is comparable to that of a coronary calcium score, under 1 millisievert in many good centers. So if you can do a mammogram or a coronary calcium score, and the many guidelines recommend repeating mammograms as well as coronary calcium scores every 5 years or so, you can get a coronary CTA to better track what's happening with plaque. The other thing I've told you is you not only get information on plaque, you get information on pericoronary fat. And we'll talk a little bit about radiomics, which are other features that artificial intelligence can use to predict risk. And you can get what I'll talk about is FFRCT, or non-invasive hemodynamic data from the CT itself without doing anything different to the CT. And so all of that all of those pieces of data together combined to give you a very good estimate of major adverse cardiovascular events, or MACE. Now, photon counting CT, which has really brought the spatial resolution of CT to 0.2 millimeters, has really allowed you to see plaque very nicely. The high spatial resolution allows you to now track plaque changes over time with great fidelity. So you'll see more and more that CT is entering the space for plaque changes and plaque regression. The other thing we've realized is when you do invasive angiography, and many times you get a report saying there's lumpy, bumpy disease or there's minimal irregularities, that's not benign. The prognosis of people who have non-obstructive coronary disease is not normal. So if you have one vessel non-obstructive coronary disease, your hazard ratio is 1.9-fold higher. If you have three vessel mild non-obstructive disease, the hazard ratio is 6-fold compared to normal individuals. So we know that atherosclerosis burden is not benign, and even though one may not have a focal tight stenosis, the comprehensive presence of atherosclerosis drives up risk. So we've become attuned to that, and so I think it's important that we look at whole heart atherosclerosis burden when trying to make decisions about how aggressive to be with primary prevention. Now, there are certain other features of plaque that I told you we can get with CT aside from just volume of plaque. And these are, what is the nature of plaque? What is the morphology of plaque? Is it rich in lipids, so-called low attenuation plaque? That's a higher risk plaque. Does it show signs that it's been having a lot of intraplaque hemorrhage and healing? Is it a very active plaque that inflames all the time? That is gauged by spotty calcification, calcium deposits in area where there's been healing. Is it outwardly expanded? Is there a lot of plaque burden in that artery? That's determined by something called remodeling index. All of these features together identify plaques that tend to rupture. And in this study done in 2009, it showed that the presence of any of these features elevated the patient's risk of having a myocardial infarction over 5 years of follow-up. That's been borne out in several other data sets. You remember the ROMICAT trial, which was done in patients with acute coronary syndromes, again, confirmed this finding that any of these plaque features that indicated high risk, including the napkin ring sign, had a higher incidence of having myocardial infarction. In the stable chest pain trials, this trial PROMISE, as well as Scott Hart, again showed that the biggest predictor for having an event down the road was the presence of low attenuation plaque. And intuitively, that makes sense. If plaque is very lipid rich, it has a higher chance of rupturing, as opposed to if it is very calcified and rock solid, then it does not tend to rupture as much. So the presence of non-calcified plaque is a serious predictor of risk. Now, CT can also identify patients who are going to develop ischemia without having to do any additional features on the CT. You don't have to give adenosine or do a stress CT perfusion. The identification of vulnerable plaques, as I showed you with spotty calcification or low attenuation, predicts ischemia. And you would say, why is that the case? It is because when you have a lot of plaque burden, that endothelium is unhealthy and it doesn't tend to vasodilate well. And the presence of extensive atherosclerosis, even if it's non-obstructive, is a marker of people who develop microvascular disease and are more likely to have ischemia on that basis. So we've used CT just even without FFRCT to identify individuals who have ischemia. Now, as I talked earlier, there's various gradations of the intensity of plaque and its risk of rupture. The worst in terms of vulnerability and increasing your risk of events is necrotic core, or what we call low attenuation plaque, less than 30 Hounsfield unit. That's seen as these black, very dark gray areas in plaque. And as you move down, shown here, and the plaque gets more calcified, the risk of rupture decreases. So when you have this 1K plaque or a single plaque that has a very high Hounsfield unit, that tells you that this is intensely or densely calcified plaque, and that tends to be more stable. Now, these individuals who have a lot of dense plaque will also have other areas of mixed plaque or low attenuation plaque. So it doesn't mean that somebody who has a 1K plaque is at low risk as an individual. No, they are still at high risk because the 1K plaque itself may not rupture, but they have multiple other plaques in their coronary tree because atherosclerosis is a diffuse process, and those other plaques that are low attenuation or mixed plaques tend to rupture more often. But this individual plaque that's very calcified is not the one that's likely to rupture. Now, we've used deep learning or machine learning to quantify people who have these features. And the reason this has become important is when I started doing this, it would take me 3 hours to measure all the plaque and quantify it in all 3 vessels and give you plaque volumes and characterize plaque. But now with artificial intelligence, this can be done within seconds or minutes. And so the power of a tool like this is can do a whole heart burden of plaque and give you percentage stenosis, and that has been shown to correlate with outcomes in several studies. So this is really becoming more it's becoming more in the clinical field that it's being adopted more often because of machine learning. So it's really entering the clinical space now. Now, we talked earlier about FFRCT, which I haven't explained fully yet, but FFRCT allows you to get a measure of ischemia across a lesion just from the CT data itself. It uses modeling of what is happening to fluid physics to determine the drop in pressure across a lesion. And the reason this is important is A, it helps you determine who's ischemic. But even in the non-ischemic, non-obstructive lesions, it tells you who's at higher risk of having a myocardial infarction down the road. And the reason being, as I mentioned, endothelial dysfunction is a predictor of MACE. So if you have an abnormal FFRCT and a high wall shear stress, that predicts lesions that are culprit lesions and more likely to rupture and produce myocardial infarctions down the road. So this is, again, like I said, one of the pieces of information that you get from the CT image that you've acquired. So we've gone away from focusing only on percentage stenosis to looking at a more holistic picture of the coronary arteries. Now, the last piece I want to talk about is perivascular inflammation. We know that the coronaries are invested with epicardial fat. And in a very interesting study paper published in Nature about 10 years ago now, investigators tried to see if they could determine changes in the attenuation or Hounsfield unit of perivascular fat, shown here in red. So when fat gets inflamed, the Hounsfield units or attenuation of fat changes. An inflamed fat in a paracrine fashion tends to make intracoronary plaques rupture. So getting data from this CT, a so-called fat attenuation index, the higher the index of inflammation, the higher the chance that somebody is going to have an MI down the road. So it's a very simple index, and it's now in a commercial platform available in Europe. And you can see here in the Scott Hart trial, the highest risk of events occurred in people who had a high fat attenuation index, as well as the presence of high risk plaques, HRP, as shown here. Those are the features we talked about earlier with low attenuation, spotty calcification, etc. Now, this was put to test in a trial called Orphan that was published in Lancet earlier this year. This is a very interesting study. They took 40,000 patients. The majority of them, 82%, did not have obstructive disease. You will notice that most of the events occurred in patients who did not have obstructive disease. So almost 3,000 events occurred in patients without obstructive disease, as opposed to a smaller number of events in patients who did have obstructive disease, just by virtue of the fact that there were many more patients who did not have obstructive disease. And then they tended to categorize in both patients, obstructive and non-obstructive disease, did the presence of fat inflammation, FAI, fat attenuation index, characterize patients' risk down the road? And you'll see the folks who had highest rates of fat attenuation index, shown here in red, had the highest rates of major adverse cardiac events. And that was true for both patients who had obstructive disease or did not have obstructive disease. So again, this was another marker, a biomarker, an imaging biomarker that you got from the same CT without doing anything different, that added more information to your predictive power. And in a large analysis of almost 175,000 patients, the imaging biomarkers, including perivascular attenuation, as well as CT high-risk plaque features, were able to better predict and add to the C statistic in terms of event prediction down the road. So again, very powerful data that is coming out that has always been available to us. We just hadn't validated and proven it up until now. One of the things that we're doing routinely these days with the availability of these plaque measurement softwares I've shown here from one commercial company that's available is you can not only measure the total plaque burden, but then classify it based on how much of the plaque is, for example, calcified, non-calcified, what is the percentage atheroma volume, and how much of the plaque is low attenuation that we talked about. And the reason this is important is we're now shifting into an era of saying, we just don't want to talk about coronary disease as a binary thing, yes or no. And we don't want to talk about coronary disease with a lens towards whether or not somebody has obstructive disease. That's important. But when we're talking about prevention, we want to be able to stage the amount of coronary disease based on how much atheroma they have and how ugly is that atheroma, because that has a direct correlation with risk. For example, if you take patients with CAD stage 3 who have more than 15% of their vessel volume invested by atheroma, they have a 10-year CVD risk that is very high, more than 15%. And what this immediately translates into, well, maybe there should be a difference in how we treat these people. Somebody with stage 1 disease who has only a minimal amount of plaque should not be treated just with a statin, should not be treated the same way as somebody who has stage 3 disease with a statin. Maybe the stage 3 person needs more intensive treatment, and that's becoming the paradigm that we're entering these days. This is another company that provides the same data in a different format. And you'll see here, as if this is the patient who refused to take a statin, initially had, 50% stenosis in the LAD, non-obstructive disease in the RCA, and over the course of 3.5 years, we're able to show a doubling of the plaque volume, as well as one of his lesions became stenotic in the LAD. And that was accompanied by a hemodynamically significant lesion where the FFRCT now became ischemic. And an abnormal FFRCT is a value of less than 0.8, and here you can see the FFR dropped from 0.87 to 0.58. So now this individual, because of expansion of atheroma volume, has not only had an increase in the percentage atheroma volume, but also has signs of ischemia. As I mentioned earlier, we want to be able to target our approach based on plaque burden. So these are two individuals, same age. One's a 54-year-old male on the left, the other one on the right is a 54-year-old female. They both were evaluated for symptoms but had negative stress echoes, i.e. no ischemia, so there's no point in taking them to the cath lab. In the very distal LAD, they have somewhat comparable FFRCT values, so on the gray zone, so nearing ischemia in a very small distal portion of the terminal LAD. So the amount of myocardium supplied is quite small, which is likely why the stress echoes in these people were negative. So there's not any substantial amount of ischemia. But obviously, you notice that individual 1 has 634 millimeter cube of plaque, which is getting to the severe grading, with stage 2, stage 3 being the worst, and the individual on the right has minimal amount of plaque. And we have nomograms, just like we have for calcium scoring, as to how much plaque is expected in men and women, depending on their age. Individual 2 has a very low percentile in terms of where they fall, and individual 1 has a very high percentile. So obviously it makes sense that we would want to be more aggressive in the first patient as opposed to the second patient. In the second patient, I would argue a statin alone should be sufficient, but that will not be sufficient in stopping disease progression in patient 1. And if you look at plaque regression with statins, there's several lines of evidence now show the same thing. A, statins may retard the progression of plaque. So in many instances, they won't cause overt plaque regression, but they will change the composition of plaque and they will slow the development of further plaque. And the way the composition changes is more plaque in patients on statin becomes calcified. And as I mentioned earlier, having individual components of plaque calcify protects the plaque from rupturing. So that's a good thing. And some of that has to do with anti-inflammatory effects and pleiotropic effects. So this is another extension of that data from another study called REPRIEVE, which was looking at patients with HIV who got pitavastatin. These, mind you, are patients who have an ASCVD 10-year risk score of less than 5%. So they would not have normally qualified for statin therapy. But because they have an inflammatory disease, i.e. HIV, the statin did in fact have a lowering of myocardial infarction risk in these people by a substantial amount. And in the folks who got CTs, there was a sub-study of patients who got CTs before and at the end of the study at 24 months. They had a decrease in low attenuation or non-calcified plaque, again, suggesting that statins will have beneficial effects in these individuals, driven not just by the lowering of LDL-C, but also by lowering of inflammation, the so-called pleiotropic effects of statins, which is particularly beneficial in individuals who have inflammatory conditions like psoriasis or HIV, et cetera. So you get a bigger bang for your buck in those individuals. Another study showing plaque regression, this time with icosapent ethyl. You'll remember that icosapent ethyl in the REDUCE-IT trial reduced events in individuals who were felt to be at high risk because of high triglyceride levels. A sub-study of that called EVAPORATE was a small study of 80 patients who got CTs again before and after icosapent ethyl. And again, you will see there was a reduction in low attenuation plaque, as well as an improvement in hemodynamic markers as assessed by FFRCT. So you get a lot of information on CT serial follow-up showing that plaque is getting passivated and the hemodynamics in the artery are also improving. Now, along the lines of inflammation, people have also studied colchicine. I'm sure all of you know the data that colchicine reduces MI in patients with stable coronary disease who've previously had an MI. That's data from LODOCO-2 and Colcott. Now, this is a CT sub-study, CT study done in patients who had previously had an ACS, again showing with colchicine at the end of 1 year, they had a change in the plaque composition. So there was lesser low attenuation plaque and more calcification of plaque. Same thing has been shown with diet. A healthy diet alone in a small study was able to reduce and change the morphology of plaque again. So I think the point I'm making is all of these technologies, all of these interventions are able to individually show a reduction in plaque and a change in more favorable plaque metrics compared to just using one drug alone. And so that got us to start this trial, which we're doing at University of Louisville. We're taking South Asian patients who, as you know, are higher risk, and everyone has non-obstructive plaque on their index coronary CT and some risk factors, such as LDL more than 70 with hypertension or diabetes or obesity. And these are folks who have never had a prior myocardial infarction, so really primary prevention patients. And we're trying to study if they would do better with more aggressive therapy. As you can see here, we're using 7 drugs in these individuals, as opposed to what is the current guideline, which is treat them with a statin or 1 or 2 other lipid-lowering medications to get their LDL below 70. The primary endpoint in this trial, called ART-CAP, is a change in plaque volume of non-calcified plaque, but we're also measuring events. We're also looking at changes in inflammatory biomarkers in serum as well as in CT, as I showed you, and doing flow cytometry for CHIP analyses. So this will be an interesting trial. We should have data in probably 2 years on this trial. There's also another trial going on, which is a bigger, much bigger randomized control trial called the TRANSFORM study. That is the similar design. It's studying 7,500 patients. And the treatment is either based on risk factors and pooled cohort equation calculation or guided by plaque burden. And this is an outcomes trial, as I mentioned. So I think the paradigm that we're seeing is we used to treat patients just based on risk factors and pooled chord equations. And with that, the area under the curve in terms of prediction of events was about 0.6, 0.7. When you add in more imaging biomarkers, such as with calcium scoring, and especially with coronary CTA, you're able to better improve your risk prediction models. And I'll argue that you're able to not just tell patients how much risk they have, how much plaque they have, but you're able to now guide your risk prevention intensity to the amount of plaque, which has always been the principle in risk and treatment of risk. You want to marry the intensity of your treatment to the risk an individual has. And I think this CTA adds to that better definition of risk in these individuals. So this is my question that I showed you in the beginning. Which of the following factors is associated with a higher risk, not associated with a higher risk? And here the answer would be the densely calcified plaque, because as I mentioned, that protects that individual plaque from rupturing. And I think I will stop there with my presentation, and I'll really look forward to the discussion.
Well, Dr. Kalra, thank you. That was an outstanding and stimulating discussion and really opens all our eyes to how to view risk in our patients. I know one question that comes up in my practice has to do with patients that go for calcium score and they come back with a LAD of 900 units and 20 in the CIRC and 20 in the RCA, and then they want to pursue more invasive strategy. How do you handle that in your practice? And also for the group, if you have any questions for Dr. Kalra, put it in the chat and I'll let him know.
Yeah, thank you, Guy. That question comes up all the time. I see at least one patient in clinic every week in my lipid clinic, because we tend to get a lot of these folks from the community. And it's a difficult question because we don't have much in the way of randomized controlled trial data for these individuals. And what do I mean by that? We know that individuals who have high calcium burden are at high risk. In fact, there's a paper last year showing that if your calcium score is more than 300, you fall in the secondary prevention risk category. So your risk is similar to somebody who's had an MI in the past. I think that's really important data because it sort of stratifies risk based on your calcium score. But what we don't have today is data showing us what should we do about individuals that are high risk overall, but who are asymptomatic. Should we cap them? Should we do stress tests? So most of the data that exists out there is expert opinions. Instead, doing a stress test for a very high calcium score was a class 2B indication, i.e., you could consider it. And these are for genuinely asymptomatic patients. I'm definitely excluding anybody with angina, because then you're talking about a whole different disease. Because we know that the angina, if you have angina, stenting is better than medical therapy in relieving angina, not specifically for reduction of events, but at least just for inner control. So we're talking only about asymptomatic patients who have very high calcium scores. Should you do a stress test? Should you do an angiogram? Should you just treat them? So that the ACC guidelines back then were 2B. Then the NLA came out with a position statement saying that it was a class 3, i.e. no benefit. And currently, the ACC sort of hews in the same direction. That is, if your patient is genuinely asymptomatic, you don't have to do any further follow-up, except we'll be very aggressive in treating them. And as I said, because of the new data showing that a calcium score more than 300 is secondary prevention, you'd want to drive down their LDL-C to below 70, or even preferably below 55, and control all the other risk factors. The challenge occurs when you see focal calcium in the left main, or if you see focal majority of calcium in the ostial LAD. And that's where it's a data-free zone. And what I do, this is my personal approach, and it's not in any guidelines. We know that if you have calcium that is more focal as opposed to diffuse, that person with the focal calcium is at much higher risk, especially if it is in critical zones like the left main or ostial LAD. Always take a look at these scans myself, because when you get the report, you typically just have a number for the RCA or the LAD. You don't know where exactly in the LAD. If it is a thorough history, I almost pester the patient to convince me that they have zero symptoms. Flights of stairs. If they have symptoms, then I'm more inclined, if they have these high-risk features, to get a stress test to actually document they have no ischemia. Because if those individuals have ischemia in the laboratory, they were not included in the ischemia trial, and their prognosis is very different. So I think that's the practical approach I take. Like I said, it's somewhat of a data looking at these people. We might get data from the confirmed 2 registry, that is a registry. So we don't have high quality RCTs as to randomizing patients who have a score of, like you said, 900 in the osteal LAD to medical therapy or doing a stress test and then seeing what happens to them. So that remains a data-free zone. Overall, for the vast majority of patients, just preventive medical therapy is all that recommended. Rarely would you recommend invasive angiography in these people.
All right, great. Thank you. As another question comes up from many of us, we get a CTA and we'll get the FFR from heart flow. And how do you find the correlation with the FFR to real world anatomy in terms of ischemic burden?
Yeah, so there's quite a bit of data from this now. There's trials from Belgium, as well as Advanced Registry in Western Europe, as well as individual registries that have gone on in this space, showing the correlation is about point. Is very robust. So 0.8 to 0.9, which is pretty good. And most of the times, the biggest utility is obviously in patients who have intermediate degree of stenosis. So I typically don't tend to do these if the stenosis is less than 40% to over 90%. And that's what the most recent ACC chest pain guidelines from 2021 also indicate, that if you have somebody with 40 to 90%, you can consider an FFRCT. Personally, for me, I tend to look at it more in the 50 to 80% range. If I have somebody with more than 80% stenosis and typical symptoms, I don't bother with FFRCTs in everybody. Occasionally, I'll do it. So the answer to your question is, for most patients, the correlation is pretty good. Where's the correlation not good? And this is really where it gets problematic. If your CT is not a good quality, so you have a very obese patient where there's a lot of noise and motion, and you get a CT scan that's not great quality, or if you did not give enough nitroglycerin before acquiring the images, that's a must for the computer models to estimate, to guesstimate flow based on these fluid dynamic equations, so-called the Navier-Stokes equations. So if you don't have a great quality CT, I often say GIGO, garbage in, garbage out. You'll get some number, but that number won't be very relevant. So you're going to have good quality CTs to get good quality data. But even having said that, if I have tons of focal calcium in a vessel, the biggest problem with CT, the Achilles heel, is focal calcium where you cannot see the lumen, i.e. circumferential ring of calcium that is so dense that the photons can't penetrate and show you what's going on in the lumen. Then all bets are off. But if you have more diffuse calcium, generally your results are fairly robust. But it's, again, you have to have good quality images, and the correlation and the technique is very important. If you look at the terminal vessel, that's not the correct place to measure the FFRCT, because you can measure it throughout the course of the vessel. You have to be within a centimeter off the lesion you're trying to assess. And in the cath lab, you have to have correlation that it was measured at the same point to get a good correlation. But if you measure at 2 geographically disparate places on CT and invasive angiogram, then obviously your numbers will be a little different. So technique is important.
Okay, great. There's another question Do you routinely prefer CTA over calcium score? They asked in patients under 40. I would even expand that. Do you prefer CCTA over calcium score in cardiovascular screening?
Yeah, that's a fantastic question. And again, we don't have RCT data, no randomized control data, to support what I'm going to tell you. But as you saw, we're doing the trials in that space to gather this data. So for individuals who you have risk enhancers, or where you have a suspicion that this individual is not being adequately captured by a current risk scoring methods, I prefer CTA, especially for the younger ones. So let me tell you why. So you have a South Asian individual who, they tend to have more adiposity on the inside, their BMI may be normal, but they have a very strong family history. And our current ASCVD risk calculator does not include family history. It does include South Asian, but more as a risk enhancer rather than an actual calculation itself. And we know that individuals typically don't tend to calcify plaque until they're into their 30s or 40s. So if you have a 25-year-old or a 30-year-old whose father had a heart attack at age 38 and they're South Asian, or you have a very high LP little a, things that are not captured by our current risk calculators just because we haven't broadened them to include everything that a patient has who's sitting in front of you, or they have lupus, or they're on antipsychotic medications. If you look at risk calculators across the world, they tend to have different variables that go into them. Some of them have CKD and atrial fibrillation and social determinants of health and stress and sleep quality. And by the way, environmental pollution that nobody's capturing, but we know definitely leads to coronary atherosclerosis. So I think the physician gestalt and appreciation of all of these risk factors and knowing the trajectory of when plaque calcifies is important in making that calculation of whether you do a CT or calcium score. If I have a 60-year-old man that I'm just trying to assess risk for the first time because they're borderline risk, then I just do a calcium score. Because by that time, if they have plaque, it'll be calcified. And then if the calcium scores, say, for example, 50 or 100, what you would expect in the norm for a slightly above risk individual, then I don't need a whole lot more information to initiate therapy. But if I have, like you said, a young individual, I feel like I'm missing the majority of risk because of the inadequacy of tools I have now, then I tend to better refine that risk. And there I would definitely do a coronary CTA. Again, this is outside the guidelines, but I think the guidelines will move there eventually once we gather this data. I should also add that that's not the only way to assess risk. A CTA is great because it shows you coronary plaque, but iliofemoral plaque detected by ultrasound, as shown in the PESA study, or if you can detect carotid plaque, which we often do in patients with familial hypercholesterolemia. There are other ways to pick up plaque and risk, including things such as biomarkers like high sensitivity CRP that nudge you to be more aggressive with therapy. I think CTA is a great tool if you're doing it in a place that can characterize plaque, has a good scanner, and can do it with low radiation. I would not do it in a place that's still giving 10 millisieverts of radiation in a 25-year-old woman. So I think it requires a little judgment and how good your program is and what are you going to use that information for. So I think if you're going to use that information to intensify therapy, in my mind, it makes sense to go that route.
Great. That was a wonderful answer. Here's another therapeutic question. Aside from aggressive lipid lowering, do you recommend aspirin in all patients with any degree of CAD without contraindications?
Yeah, again, there the data is if you have a calcium score of more than 100, which is what the SCCT guidelines have shown and work from Michael Medema and Blaha's group has shown, you need to have a certain amount of plaque burden before you start recommending aspirin, because as you know, the risk-benefit ratio for aspirin is a very narrow therapeutic window. It's typically in middle-aged men with higher than average risk and a low bleeding risk. So you really have to try to fit into that small window to have any benefit of aspirin. So no one has systematically studied in terms of millimeter cube of plaque, how much that turns out to be. I don't know whether it'll turn out to be 100 millimeter cube of plaque or 250 millimeter cube of plaque, where aspirin has been will show to have a benefit. But at least for the calcium scoring data, for the studies that have looked at MESA and other databases, Calcium Consortium, a score of 100 is sort of where you draw the make the cutoff. If you're using the pooled cohort risk equation, then obviously you want to have a 10-year risk of 7.5 to 20%, so intermediate risk or higher. And in a man who's typically between 40 and 70, the ACC gives it a class 2B indication in those individuals. So you may consider it. I think we moved away from aspirin for the vast majority of our patients, except that select group that is particularly at high risk.
Okay, terrific. What do bilateral carotid bulb plaques signify on contrast MRI in a patient already on moderate intensity statin therapy? So what more would you do? And do we have to worry when they come back with some carotid bulb plaque?
Yeah, so carotid plaque is actually much more robust of a risk marker than carotid intermediate thickness. So when we look at ultrasound, I know your questions about MRI, I'll get to that in a second, but the problem with CIMT as a risk biomarker, imaging biomarker, and the reason it fell out of favor is because of the variability in CIMT readings at the same center, the same reader, just because the technique is so operator dependent. If you shift the probe one way or the other, and whether you measure the near wall or the far wall of the carotid, and where you measure the bulb, internal carotid, common carotid, all of those features would make a difference, that the very thin layer of IMT that you had, you would get very different results. So that's why its C statistic was never better than just risk factors alone. And that's why calcium scoring really went into play. But carotid plaque, if you can measure amount of plaque using current ultrasound technology, especially 3D ultrasound and contrast ultrasound, is very robust. It does give you good information. MRI does even better because it not just quantifies the amount of plaque, you can actually measure inflammatory plaque, vulnerable plaque, plaque that's necrosed inside. So we have different sequences on MRI that can talk about the aggressiveness of plaque. So your question being, if you have bilateral carotid artery plaque in somebody who already is on treatment, I would say you would look at things such as T2 intensity, so a marker of edema and inflammation in the plaque. And if you had any features of vulnerability of the plaque, such as low attenuation or low signal intensity indicating necrosis, then you would want to intensify treatment. So, there you would want to get the LDL down to under 55 and make sure the LP little a is under control, and you're doing everything else in terms of global risk reduction in that individual.
Terrific. And would you add aspirin to that individual with the carotid plaque?
I probably would.
Basic?
I probably would, because as you remember, Dr. Mintz, the earlier data on aspirin, when used for primary prevention, was especially useful for stroke prevention in women. And so, if this individual has nasty looking plaque or ulcerated plaque, any features of high risk, I would do it for the cerebrovascular protection. As you know, the carotid plaque is a stronger predictor of cerebrovascular events as opposed to coronary plaque. There's some correlation there also, roughly in the 0.7 range, but carotid plaque is the best predictor for future strokes.
Okay, good answer. And how far do you think we are from getting more comprehensive CTA reports like you were referring to this evening, with degree of inflammation and degree of fatty fibrous? Because most of us get a report back, heterogeneous plaque, minimal less than 25%, moderate less than 50%, and then maybe beyond that we get an FFR. So how far are we away from such a comprehensive insight into the plaques?
Yeah, so both of these companies that I mentioned, and there's a few others in the space, have been providing plaque metrics and data for about 2 years now. Now, how long will that take to penetrate into community imaging centers? I suspect it'll be another 3-4 years. And that's not just because you can get the plaque information, but the CTs have to be of amazing quality. So you have to have, technically beautiful CT scans done with modern scanners such as photon counting or dual source scanners or a 320 slice scanner. Not all centers have the capability to do advanced CT imaging, which has been one of the challenges, but most academic and larger centers that do high volume CTAs do have those capabilities. And now reimbursement is changing such that plaque is getting reimbursed by some insurers. So there's more of an incentive to do it and get that comprehensive information. And patients are starting to get a comprehensive report that tells them how much plaque there is. So as you remember, when we first started doing calcium scoring, we would give our reports to patients, or I would actually show them, look, this is your calcium in your LAD. I think this is why it makes sense for you to take a statin. And then the vast majority of them would agree. In fact, the Eisner trial proved that once you showed patients how much plaque they had, they were more likely to comply, not just with lipid lowering therapy, but with blood pressure therapy and weight loss and diet and all of that. So I think the companies now are not just providing a comprehensive report to the doctor, but also to the patient. And I think that'll really, patients are going to want to demand to know, well, what is going on in my coronary tree? How much plaque do I have? And then subsequently, is this changing? Just like, when you give people a lipid panel, they want to see if their LDL went down on the drugs you put them on. They need something to hang on to see if what they're doing is working. And so I think this will become more commonplace as we go along. But to penetrate everywhere, I think it'll take 3 to 5 years.
Okay, and we have just one last question before we wind down. How often would you repeat a CTA?
Yeah, that's again a challenging question because we don't have data on, should you repeat it every 18 months like we're doing in a trial? Should you repeat it 5 years? I think changes in plaque, measurable changes in plaque using current technology take at least 6 months. So we chose 18 months for our trials endpoint. A lot of other trials that have looked at plaque have also chosen 18 months because it gives you enough leeway to actually make measurable changes. With photon counting, some of those changes, because your spatial resolution is so much better, may even be shorter amounts of time. So to answer your question, I would say, well, if you're trying to achieve, I think every time I do a test, the first question I ask myself is, what am I going to do with the results of that test? So if your patient's not going to be willing to take any more medications, then I probably wouldn't repeat the test. But if you feel like you have additional agents in your armamentarium that you would add, for example, you get a new LPA lowering therapy in a year or two, and the individual has high LPA and more plaque, and if I'm going to make a determination that I'm going to add that therapy, if the individual's plaque is increasing, then I would probably repeat it in 2 years or 3 years to see how we're doing in terms of plaque regression and plaque vulnerability. But this is sort of a data-free zone. I think the trials that are going on in the space will inform us more. The 2 trials I mentioned, ours is a small trial, Transform, and then Confirm 2 is a larger registry, some of which will have patients who get repeat scanning. So we'll be able to tell what is the duration of time during which you can see meaningful differences in patients who have been started on therapy.
All right, well, that was super. I want to thank Dr. Kalra for giving us time this evening. It was amazing, opening up new diagnostic worlds for us, and the future is also bright, illuminating. For everyone who joined us tonight, we'll be having our next Neela Nights in December on ApoC3 and hypertriglyceridemia. But I also remind everyone that the last Tuesday of every month is a lipid panel, which is an interesting group of challenging cases that we'd see with 2 experts and a moderator and a junior faculty presenter. So please join us then as well. And thank you to everyone joining us, and especially Dr. Kalra for an outstanding presentation. Thank you.
My pleasure, Guy. Thank you. Thanks for everyone for joining.